Delirium or acute confusional state is a syndrome that presents as severe confusion and disorientation, developing with relatively rapid onset and fluctuating in intensity. It is a syndrome which occurs more frequently in people within their later years. Delirium represents an organically caused decline from a previously attained baseline level of cognitive function. It is typified by fluctuating coarse attentional deficits and generalized severe disorganization of behavior. It typically involves other cognitive deficits, changes in arousal, hyperactive, hypoactive or mixed, perceptual deficits, altered sleep-wake cycle and psychotic features such as hallucinations and delusions. Delirium itself is not a disease, but rather a clinical syndrome, which results from an underlying disease from medications administered during treatment of that disease in a critical phase or from varying combinations of two or more of these factors. In common usage, delirium is often used to refer to drowsiness, disorientation and hallucination. In medical terminology, however, a number of different symptoms including temporary disturbance in consciousness with reduced ability to focus attention and solve problems are the core features of delirium. Occasionally, sleeplessness and severe agitation and irritability are part of delirium. Hallucination, drowsiness and disorientation are not required, maybe contribute to the diagnosis. The core features are disturbance of consciousness, that is reduced clarity of awareness of the environment with reduced ability to focus, sustain or shift attention. Change in cognition, problem solving impairment or memory impairment or a perceptual disturbance, that is hallucination. Onset of hours to days and tendency to fluctuate. Behavior may be either overactive or underactive and sleep is often disturbed with loss of the normal circadian rhythm. Thinking is slow and muddled, but the content is often complex. Other clinical features include disorganized thinking, poor memory, delusions and mood changes. Now, signs and symptoms of delirium. Delirium is a syndrome encompassing an array of neuropsychiatric symptoms including a disturbance in consciousness or attention and cognition that develops acutely and tends to fluctuate. The change in cognition, that is memory deficit, disorientation, language disturbance or the development of a perceptual disturbance must be one that is not better accounted for by a pre-existing established or evolving dementia. Other symptoms can include disorientation, thought disorder, memory problems, language disorder, sleep disturbance, delusions, mood lability, psychomotor changes and hallucinations. Delirium occurs as a stage of consciousness in the continuum between normal awakeness or alertness and coma. During the 20th century, delirium was described as a clouding of consciousness, but this rather nebulous concept has been replaced by a better understanding of the components of phenomenology that culminate in severely impaired higher order brain functions. Lipovsky described delirium as a disorder of attention, wakefulness, cognition and motor behavior, while a disturbance in attention is often considered the cardinal symptom. Disrupted sleep-wake cycles can result from a loss of normal circadian rhythm. Accumulating evidence indicates three core domains of delirium phenomenology: cognition composed of inattention and other cognitive deficits, higher level thinking processes including impaired executive function, semantic expression and comprehension, and circadian rhythm including altered motor activity and fragmented sleep-wake cycle. Phenomenology studies suggest that core symptoms occur with greater frequency while other less consistent associated symptoms may reflect the biochemical influence of particular etiologies or genetic, neuronal or physiological vulnerabilities. Inattention and associated cognitive deficits. Inattention is the cardinal and required symptom to diagnose delirium and is noticeable on interview by distractibility and inability to shift and or sustain attention. More formal testing can include the months of the year backwards, serial sevens or digit span tests. Disorientation describes the loss of awareness of the surroundings, environment and context in which the person exists. It may also appear with delirium, but it is not required as noted. Disorientation may occur in time, not knowing what time of the day or time of week, month, season or year it is, or place, not knowing where one is, or person, not knowing who one is. Memory impairment occurs and is linked to inattention, reduction in formation of new long-term memory, which by definition survives withdrawal of attention, is common in delirium because initial formation of long-term memories generally requires an even higher degree of attention than do short-term memory tasks. Since older memories are retained without need of concentration, previously formed long-term memories, that is those formed before the period of delirium, are usually preserved in all but the most severe cases of delirium. Higher level thinking processes. Delirium patients have diminished comprehension as evidenced by reduced grasp of their surroundings and difficulties in connecting with their immediate environment, executive dysfunction affecting abstraction, initiation and perseveration, switching mental sets, working memory, temporal sequencing and organization, insights and judgment. Though none of these cognitive deficits is specific to delirium, the array and pattern is highly suggestive. Language disturbances in delirium include anomic aphasia, paraphasias, impaired comprehension, agraphia and word finding difficulties. Incoherent or illogical rambling conversation is reported commonly. Disorganized thinking includes tangentiality, circumstantiality and a proneness to lose association between elements of thought, which results in speech that often makes limited sense with multiple apparent irrelevances. This aspect of delirium is common but often difficult for non-experts to assess reliably. Circadian disruption. Disruption of sleep-wake cycle is almost invariably present in delirium and often predates the appearance of a full-blown episode. Minor disturbances with insomnia or excessive daytime somnolence may be hard to distinguish from other medically ill patients without delirium, but delirium typically involves more substantial altercations with sleep fragmentation or even complete sleep-wake cycle reversal that reflect disturbed circadian rhythm regulation. The relationship of circadian disturbances to the characteristic fluctuation, severity of delirium symptoms over a 24-hour period or to motor disturbance is unknown. Motor activity alterations are very common in delirium. They have been used to define clinical subtypes, hypoactive, hyperactive or mixed, though studies are inconsistent as to the prevalence of these types. Cognitive impairment and EEG slowing are comparable in hyperactive and hypoactive patients, though other symptoms may vary. Psychotic symptoms occur in both, although the prevailing stereotype suggests that they only occur in hyperactive cases. Hypoactive cases are prone to non-detecting or misdiagnosing as depression. A range of studies suggest that motor subtypes differ regarding underlying pathophysiology, treatment needs and prognosis for function and mortality through inconsistent subtype definitions and poorer detection of hypoactives and impacts interpretation of these findings. Psychotic symptoms occur in up to 50% of patients with delirium. While the common non-medical view of a delirium patient is one who is hallucinating, most people who are medically delirious do not have either hallucinations or delusions, though content abnormalities include suspiciousness, overvalued ideation and frank delusions. Delusions are typically poorly framed and less stereotyped than in schizophrenia or Alzheimer's disease. They usually relate to persecutory themes of impending danger or threat in the immediate environment, for example, being poisoned by nurses. Misperceptions include depersonalization, delusional misidentifications, illusions, and hallucinations. Hallucinations and illusions are frequently visual, though can be tactile and auditory. Abnormalities of affect which may attend the state of delirium may include many distortions to perceived or communicated emotional states. Emotional states may also fluctuate so that a delirious person may rapidly change between, for example, terror, sadness, and jocularity. So, what causes delirium? Delirium arises through the interaction of a number of predisposing and precipitating factors. A predisposing factor might be any biological, psychological, or social factor that increases an individual's susceptibility to delirium. An individual with multiple predisposing factors is said to have high baseline vulnerability, and this is closely associated with frailty. A precipitating factor is any biological, psychological, or social factor that can trigger delirium. The division of causes into predisposing and precipitating is useful in order to assess an individual's risk of suffering and delirium. And in guiding the management of delirium, however, there may be a significant degree of overlap between the two categories. Delirium most commonly affects the frail and infirm. Frailty is usually the result of multiple physical and social causes and is often viewed as a symptom of old age or ill health. Health can be described as a balance between fitness and frailty, in which fitness results from physical and socioeconomic assets and frailty results from physical and socioeconomic deficits. Frail individuals, that is those with significant predisposing factors, demonstrate an inability to compensate for additional physical or social stressors, that is precipitating factors. In a frail individual, a single or mild precipitating factor could be sufficient to trigger an episode of delirium. Conversely, delirium may only result in a fit individual if they suffer serious or multiple precipitating factors. It is important to note that the factors affecting the fitness or frailty of an individual can change over time. Thus, an individual's risk of delirium is in a state of flux. Predisposing factors. The most important predisposing factors are listed as older age, cognitive impairment, dementia, physical comorbidity, psychiatric comorbidity, sensory impairment, functional dependence, dehydration, malnutrition, drugs and drug dependence, alcohol dependence. The precipitating factors could be as follows: any acute factors that affect neurotransmitter, neuroendocrine or neuroinflammatory pathways can precipitate an episode of delirium in a vulnerable brain. Clinical environments can also precipitate delirium, and optimal nursing and medical care is a key component of delirium prevention. Some of the most common precipitating factors are listed below: metabolic, malnutrition, dehydration, electrolyte imbalance, anemia, hypoxia, hypercapnoia, hypoglycemia, endocrine disorders, especially respiratory and urinary tract infections, medication, infection, anticholinergics, dopaminergics, opioids, steroids, recent polypharmacy, vascular like stroke or transient ischemic attack, then myocardial infarction, arrhythmias, decompensated heart failure, and physical and psychological stress, pain, iatrogenic event especially post-operative, mechanical ventilation in ICU, chronic or terminal illness especially cancer, post-traumatic event for example fall, fracture, immobilization restraint, and others could be substance withdrawal especially alcohol, substance intoxication or traumatic head injury. Now the treatment. Treatment of delirium involves two main stages. First, treatment of the underlying presumed acute cause or causes. Secondly, optimizing conditions for the brain. This involves ensuring that the patient with delirium has adequate oxygenation, hydration, nutrition, and normal levels of metabolites, that drug effects are minimized, constipation treated, pain treated, and so on. Detection and management of mental stress is also very important. Therefore, the traditional concept that the treatment of delirium is treat the cause is not adequate. Patients with delirium actually require a highly detailed and expert analysis of all the factors which might be disrupting brain function. Then we get to the amnestic disorders. The amnestic disorders are a group of disorders that involve loss of memories previously established, loss of ability to create new memories, or loss of the ability to learn new information. As defined by DSM-4-TR, the amnestic disorders result from two basic causes: general medical conditions that produce memory disturbances and exposure to a chemical, drug of abuse, medication, or environmental toxin. An amnestic disorder whose cause cannot be definitely established may be given the diagnosis of amnestic disorder, not otherwise specified. The amnestic disorders are characterized by problems with memory function. There is a range of symptoms associated with amnestic disorders as well as differences in the severity of symptoms. Some people experience difficulty recalling events that happened or facts that they learned before the onset of amnestic disorder. This type of amnesia is called retrograde amnesia. Other people experience the inability to learn new facts or retain new memories, which is called anterograde amnesia. With people having amnestic disorders, they do not usually forget all of their personal history and their identity, although memory loss of this degree of severity occurs in rare instances in patients with dissociative disorders. The signs and symptoms of amnestic disorders. In addition to problems with information recall and the formation of new memories, people with amnestic disorders are often disoriented with respect to time and space, which means that they are unable to tell an examiner where they are or what day of the week it is. Most patients with amnestic disorder lack insight into their loss of memory, which means that they will deny that there is anything wrong with their memory in spite of evidence to the contrary. Others will admit that they have a memory problem but have no apparent emotional reaction to their condition. Some persons with amnestic disorders undergo a personality change. They may appear apathetic or bland, as if the distinctive features of their personality have been washed out of them. Some people experiencing amnestic disorders confabulate, which means that they fill in memory gaps with false information that they believe to be true. Confabulation should not be confused with intentional lying. It is much more common in patients with temporary amnestic disorders than it is in people with long-term amnestic disorder. Transient gold amnesia is characterized by episodes during which the patient is unable to create new memories or learn new information, and sometimes is unable to recall past memories. The episodes occur suddenly and are generally short. Patients with TGA often appear confused or bewildered. Diagnosis. Amnestic disorders may be self-reported if the patient has retained insight into his or her memory problems. More often, however, the disorder is diagnosed because a friend, relative, employer, or acquaintance of the patient has become concerned about the memory loss or recognizes that the patient is confabulating and takes the patient to a doctor for evaluation. Patients who are disoriented or whose amnesia is associated with head trauma or substance abuse may be taken to a hospital emergency room. The doctor will first examine the patient for signs and symptoms for traumatic injury, substance abuse, or general medical condition. He or she may order imaging studies to identify specific areas of brain injury or lab tests of blood and urine samples to determine the exposure of environmental toxins or recent consumption of alcohol or drugs of abuse. If general medical conditions and substance abuse are ruled out, the doctor may administer a brief test of the patient's cognitive status, such as the mini mental state examination. The doctor may also test the patient's ability to repeat a string of numbers in order to rule out delirium. Patients with amnestic disorder can usually pay attention well enough to repeat a sequence of numbers, whereas patients with delirium have difficulty focusing or shifting their attention. In some cases, the patient may also be examined by a neurologist. If there is no evidence of a medical condition or substance use that would explain the patient's memory problems, the doctor may test the patient's memory several times in order to rule out malingering or a vexatious disorder. Patients who are faking the symptoms of an amnestic disorder will usually give inconsistent answers to memory tests if they are tested more than once. DSM-4-TR specifies three general categories of amnestic disorders. These are amnestic disorders due to a general medical condition, substance-induced persisting amnestic disorder, and amnestic disorder not otherwise specified. The basic criterion for diagnosing an amnestic disorder is the development of problems remembering information or events that the patient previously knew, or inability to learn new information or remember new events. In addition, the memory disturbance must be sufficiently severe to affect the patient's social and occupational functioning and to represent a noticeable decline from the patient's previous level of functioning. DSM-4-TR also specifies that the memory problems cannot occur only during delirium, dementia, substance use or withdrawal. Causes of amnestic disorders. In general, amnestic disorders are caused by structural or chemical damage to parts of the brain. Problems remembering previously learned information vary widely according to the location and the severity of brain damage. The ability to learn and remember new information, however, is always affected in an amnestic disorder. Amnestic disorder due to a general medical condition can be caused by head trauma, tumors, stroke or cardiovascular disease. Substance-induced amnestic disorder can be caused by alcoholism, long-term drug use or exposure to such toxins as lead, mercury, carbon monoxide, certain insecticides. In cases of amnestic disorder caused by alcoholism, it is thought that the root of the disorder is a vitamin deficiency that is commonly associated with alcoholism, known as Korsakoff syndrome. The cause of transient global amnesia or TGA unclear. Treatment. There are no treatments that have been proved effective in most cases of amnestic disorder as of 2002. Many patients recover slowly over time and sometimes recover memories that were formed before the onset of amnestic disorder. Patients generally recover from transient global amnesia without treatment. In people judged to have the signs that often lead to alcohol-induced persisting amnestic disorder, treatment with thiamine may stop the disorder from developing. Now the summary. Delirium is characterized by severe confusion and disorientation with rapid and fluctuating presentation. Delirium is caused due to many predisposing and precipitating factors. Its treatment involves treating the underlying cause and optimizing brain functions. Amnestic disorders are characterized by loss of previous memory or ability to form new memories. It is caused due to structural or chemical changes in the brain. No specific treatment is available and patients tend to improve with time.